Regarding the history and examination format of a diabetic kidney disease. So again, in diabetic kidney disease also, you have to divide that into 5 parts so that you won't miss any of the components. As I told in the glomerular disease, the first part is the details of the basic details of the patient, include regarding the history, uh, who told the history and how was the reliability. That also here. Other than that, same as that I told in the glomerular disease. With respect to the part B, this is the important part where we will be getting the maximum information regarding the patient and the diagnosis. After the part B, a summary have to be made, and part C, part D are the examination part, general, systemic, and then the general we are having the usual examination, then the head to core, and finally is the part E. After this, you have to make a complete diagnosis. So in a diabetic kidney disease or a diabetic nephropathy, it might be a short case or long case, depends on the associated history and the patient profile. So what are the things you should be aware of before proceeding with the history taking of the diabetic patient? You should know what are all the kidney involvement in a case of diabetes. It can be in the form of diabetic nephropathy, non-diabetic kidney disease. It might be in the form of any glomerular disease. And if the older age, dysproteinemia is more common, membranous nephropathy is more common. If it is acute renal dysfunction, then you should be aware of what are the other conditions like acute interstitial nephritis, UTI, obstructive uropathy. These are all the more common conditions in a diabetic patient. And regarding the diabetic nephropathy, you should know the time course of the diabetic nephropathy. In a diabetic patient, when the kidney usually gets involved, you should know the Mobenson classification of the time duration. Basically, that is for the type 1 diabetes, where he described the histological, clinical, and the manifestation which occur over a period of years. It is of 5 stages. You can go through it. The stage 1 is stage of hyperfiltration, and second is the stage of silent stage. Like that that duration is from 1 year to up to 6 years. From the 6 to 15 years, you are having the stage 2, which is the stage of incipient stage, where the microalbuminuria is common. From 15 to 25 years, overt stage, then finally the ESRD stage. Here the macroalbuminuria is common, and you should know what is the rate of progression after the onset of macroalbuminuria. The rate of progression of GFR is more than 10 ml per year. So this is the usual rate of progression after the onset of macroalbuminuria. So you should know the time duration, how the kidney is being affected in the case of diabetic nephropathy. This is very important because the history have to be focused to pick up these changes from the patient profile. And suppose if the patient is having onset of kidney dysfunction here and he reaches CKD within 2 years only, then you have to find out, you should be aware of what are the risk factors which causes the rapid deterioration of the renal function, like smoking, uncontrolled diabetes, uncontrolled hypertension, any associated superadded non-diabetic kidney disease, then family history. These are all some of the few important risk factors which might result in uncontrolled diabetes, hypertension, family history, superadded other kidney disease, recurrent UTI, post-infectious GN. These are all the conditions which might lead to the rapid deterioration of the renal function. This you have to be aware. And what are the complications like the diabetic patient might have? It might be because of the diabetes itself and because of the diabetic nephropathy. The diabetic nephropathy usually lead to the CKD. So all the complications related to CKD you should ask for, and all the complications related to the diabetes you should ask for. So this is the information you should be aware of before proceeding with the history. Again, the second part consists of these component history of presenting implies past, personal, family, and the usual history. Through these components, we are going to get those details that I mentioned above. Regarding the first part, it is similar to those I have mentioned in the glomerular disease only. Regarding the sequence, you can rearrange, but for the beginning, you have to remember that 1 to 11 history components have to be asked. Depends on the patient symptoms, you can rearrange accordingly. It is common for almost all the cases, whether it is a DKD or post-transplant or it is a glomerular disease. It is almost common for almost all the cases. Just go through the video of the glomerular disease where I discussed about all these things. In the kidney, you have to ask regarding the symptom related to glomerulonephritis, related to CKD like nocturia, and the important thing is the renal stone disease and the lower urinary tract symptom. This is very important in the case of diabetic kidney disease because you have to ask for storage symptoms like urgency, frequency, incontinence, and a poor stream, and post micturition dribbling is there or not. This history is important because many of the diabetic patient might be having diabetic cystopathy. So this history is very important. So don't miss this history in the renal component. Other than that, in the cardiac component, lung, GI component, it's almost same. You can go through that video. And coming to the CNS component, ask for seizure, headache, autoimmune component, because this is also very important because you have to find out the non-diabetic kidney disease etiology. Sometimes it might be superadded with some other glomerular disease, so this history also important. History related to SLE, onca, hypothyroidism, scleroderma, just as a part of negative history you have to ask this. Regarding infection, blood transfusion history is important, and COVID history is also important. Malignancy, because more than 60 years they are more prone for dysproteinemia, because diabetic patient more than 60 years usually the cases of old age, so dysproteinemia is an important differential diagnosis, though this history is also important. Coming to the hypertension history, how was the control, what are the drugs he was taking, whether the secondary components is there or not, episodic weakness, palpitation, like other histories suggest your secondary etiology, any obesity is there or not, that have to be mentioned. Coming to the diabetes, like this I will separate discuss here. With respect to the diabetes, the history might be starting in the first component of the history of presenting complaints, depends on the patient profile, the order you rearrange. And with respect to the diabetes, what are the important things you have to ask? You should tell about how it was diagnosed, why the patient underwent investigation. For example, if it was diagnosed 20 years back, you have to tell why it was diagnosed, whether during the routine evaluation, does he had any complaint, or based on what investigation, whether it is based on HbA1c, whether it is based on this OGTT or FPS, whatever it is, that have to be mentioned. And you have to mention how was the control, what are the drugs he was taking, whether he was compliant or not. Why this is important? Because any uncontrolled sugar is an important risk factor for rapid deterioration of the renal function, though this history is very important. And regarding the diet, what was the diet he is following? It is not important to mention what are the components he is taking. Overall, you have to just show the examiner that you have asked regarding the diet, because diet compliance is also an important component of the diabetic overall management. And how was the monitoring done, whether he monitored only with the FPS, PPPS or HbA1c. If the HbA1c was done, majority of the patient used to tell the values, because if it is more than 10, that indicates poor control and there is high chances of progression. And one more important point with respect to is regarding the side effect of the drug. For example, some patient might be on SGLT2 inhibitor, some patient might be on AC inhibitor with respect to the renal protection in the diabetes. So then and there only you have to tell about he was on this drug and there was no history of any hypoglycemia, UTI, weight loss was there or not. These are the important component to mention, because SGLT2 inhibitor, there is a high chance patient will be there's high chance he might develop UTI. So these components you have to mention. And if the patient drugs was changed from one to another, you have to be aware why it was changed, because there are few anti-diabetic drugs which are nephroprotective and if you have less nephroprotection. So why the doctor have changed that? What were the complication he developed? This have to be focused on. And the other history you should not miss with respect to the diabetes is that you have to focus on the 3 microvascular complication, 3 macrovascular complication. The microvascular complication is the diabetic retinopathy, diabetic nephropathy, diabetic neuropathy. Diabetic nephropathy, the initial kidney complaints I have mentioned. In the macrovascular complication with respect to coronary artery disease, peripheral vascular disease, and the CVA, any central nervous involvement. So with respect to the diabetic neuropathy, we have to ask history related to the peripheral nervous system. For the sensory involvement, you have to ask for any tingling, numbness, whether he able to feel the ground while walking, whether he is feeling cotton wool spots while walking, whether giddiness while washing the face in the wash basin, because that indicates the posterior column involvement. And regarding whether he able to feel the clothes or not, whether he is having control over the bladder, these are all the important sensory component you have to ask for. And any history suggests your posterior intervertebral disc involvement, because this is one of the differential diagnosis for the back pain, any radiating pain, radiculopathy. These are all the important negative history or positive history you have to mention for, because in diabetes there is a high chances of patient might be having distal symmetrical sensory motor neuropathy. Whenever there is a diabetic nephropathy, during the same time duration, the patient might have developed the neuropathy also. With respect to the motor, you have to ask for proximal and distal muscle involvement. For the proximal, you can ask for whether he is able to raise the limbs, whether he is able to get up from the squatting position. For the distal, you have to ask for the whether he is able to pull the slippers, whether buttoning of the shirt is there or not. Proximal, and one more point is you can tell about whether he is able to comb the hair or not. For the autonomic nervous system, you have to ask regarding the any localized sweating, alternating constipation or diarrhea, erectile dysfunction, giddiness on standing, because that is one of the important finding, which is orthostatic hypotension. So the history have to be clear with the giddiness, whether you are telling about this posterior column involvement, because the giddiness is more on the like in the dark, whereas this is because of orthostatic, which usually occurs after standing, immediately after standing. So the history have to be very clear, because for giddiness it might be because of the visual pathway or posterior column pathway or the vestibular pathway. Like similar to the medicine history, you have to differentiate which is what. And with respect to the CNS, you have to tell about the third nerve, sixth nerve prominently, whether any visual difficulty is there or not, and regarding the coordination, whether he is able to do the household activities there or not. With respect to the eye, because diabetic retinopathy is an important finding in the case of diabetic nephropathy. So all the history related to the retinopathy have to be asked. Importantly, visions, you can ask for floater, presence of cataract. So any surgery was done, how was the progression? Suppose if the patient is having visual blurring, how was the progression? And any drugs was given, because anti-VEGF they used to give for proliferative diabetic retinopathy, that is having important side effect with respect to the kidney also. So that have to be asked whether it was given intraocular or not. And how was his color vision? So those are all the important history with respect to the vision you have to mention. Coming to the macrovascular complication, any limb ulceration, distal bluish color discoloration in the lower limb, whether any history of amputation, gangrene, blackish discoloration. These are all the important history you have to be asked with respect to the peripheral vascular disease. Diabetic foot ulcer are common in the lower limb, more of the arterial ulcers. CVA, since there while telling the CNS part only, you can tell regarding the history of any past CVA or not. With respect to coronary artery disease, tell about the angina, like exertional angina. These histories are jumbled, just you have to make it in a sequence. You are covering those symptoms only once. Suppose if you have told these symptoms there, no need to repeat it here, because for the ease of remembering the histories to be asked, I have arranged like this. Since CNS is coming here also, like CNS heart is coming here, which is coming in the history of presenting complaints in the initial part. So you can rearrange accordingly as per the patient profile. And coming to the other important organ involvement you have to rule out is the diabetic cystopathy, diabetic gastropathy. The symptoms are similar to, as I mentioned, the initial part, that is the lower urinary tract symptoms of storage, voiding, the post-micturition symptom, diabetic gastropathy in the form of recurrent vomiting, gas, like gastroparesis symptoms you have to mention. Regarding the diarrhea also you have to mention, and the diabetic skin changes. For this you have to aware of what are the diabetic skin changes which can occur. And throughout the thing, how was the sugar control, and how he was taking the drugs or not, and what was the residual urine output you have to mention. So with respect to diabetes, you have to tell how it was diagnosed, what are the drugs he is on, is there any side effect of the drugs, and how was the diet compliance, 3 microvascular complication, 3 macrovascular complication, and 3 other organ system in one. So this is the important history with respect to the diabetic case. This should not be missed. And once that complications of the diabetes is crossed, then regarding the complications of diabetic nephropathy, suppose if the patient have reached the stage of CKD, or if it is a case of diabetes with renal dysfunction, whether it is AKA or CKD, if it is CKD, whether the complication is there or not, features of anemia, bone pain, any fracture, chronic itching, seizure, this might you have covered in the previous part only, and the general, like how was the well-being, whether he was able to sleep, how was his quality of the life, that have to be mentioned. Regarding the residual urine output, whether it is decreasing or static, and what was the approximate urine output, how many times he is passing. And the history of nocturia is also very important, like in the initial part only you mention about those. And suppose if the patient is on dialysis, suppose a diabetic patient on dialysis or a post-renal transplant case, the history with respect to RRT also should be mentioned. Like here, the important point to focus on is the vascular access, because diabetic patients are more prone for vasculopathy, which results in AV fistula failure. So that part have to be focused on. And the rest of the history is similar to the, like as I mentioned, the post-transplant case. You have to tell regarding why the dialysis was started, why the fistula was failed. Almost the history is same. And regarding the detailed history with respect to RRT, we will see in the CKD MHD case. Same regarding the hypotension, any blood transfusion, that have to be, this is important here. And regarding how was the ultrafiltrate, that is also important history, even in a diabetic patient who is on RRT. And regarding the past history, same personal diet history is important. Here no need to mention how much exact calorie he is taking. You have to be aware of what was his diet compliance, whether he is following dietitian or not. On an average, what is the diet he is taking. Regarding the nutrition, and what are the questions they might ask in the nutrition and nephrology part, that I will make a separate video. And with respect to the family history is also very, very important, because any family member who is having diabetic nephropathy, there is high chances this patient will also have a rapid progression, because the chances approximately 70 to 20% if there is no family history, and it increases to 70 to 80% if there is a family history. This is the theoretical part which is mentioned in some articles. So this is very important with respect to the family history and drug history, either here and the history of presenting illness. Usually in the drug history, you have to tell currently what is the drug the patient is on. And regarding the history of presenting illness before the past history only, you should have mentioned in the what was the course during the hospital stay. If the patient admitted for any renal dysfunction, how was the progression? That is an important part. Course during hospital stay, that you have to mention before the past history. So after the history of presenting complaints till the drug history, you should have an approximate idea whether it's a diabetic nephropathy or associated non-diabetic kidney disease is there or not. And suppose if it is a diabetic nephropathy, whether it is a usual rate of progression or not. For that table is very important. The table is given clearly in up to date. You can go through the non-diabetic kidney disease. If it is there, what is the first differential diagnosis? Suppose if it is a rapidly progression of the diabetic nephropathy, what is the differential diagnosis? Whether it is UTI or post-infectious GN, whether dysproteinemia is associated or not. Suppose with respect to the drug control also, you have to be aware, and what are the complications he is having with respect to diabetes, whether there's a microvascular or macrovascular. If it is a diabetic nephropathy or the kidney involvement, what are the complications secondary to that, whether he is in volume overload, uremia is there or not. These are all the idea you are having after completion of the history. So after this, you should tell the clear summary in your own language. For example, 52-year-old male who is a diabetic for the past 15 years presented with features of kidney involvement in the form of anasarca, proteinuria with a rapidly deteriorating renal function, and he underwent investigation where the kidney investigation creatinine showed 2. Like that, you have to form in your own language a short, crisp summary. After this is required, and your diagnosis followed by the differential diagnosis. What is the syndromic diagnosis and what is the etiological diagnosis, with the probability of etiological diagnosis probably type 2 diabetic with the diabetic nephropathy, nephrotic syndrome with diabetic nephropathy without any other microvascular complication, or with the history suggestive of other microvascular complication in the form of retinopathy, neuropathy, and macrovascular complication in the form of peripheral vascular disease. Like that, we have to finish. The examination also we will see now. With respect to the examination in the diabetic kidney disease, you should not miss some of the important findings that I am mentioning over here. Again, the part C consists of 2 parts: general examination and the head-to-foot examination, and the systemic examination. Finally, is the urine examination. In the general examination, the important part is rest of the things are same as I discussed in the glomerular disease case. Pulse you should not miss, because pulse is very important for the peripheral vascular disease. Usually, dorsalis pedis, posterior tibial, anterior tibial have to be checked in a diabetic case, because that is one of the signs of peripheral vascular disease, which you might tell that is the point favoring diabetic nephropathy, because patient is having patients of peripheral vascular disease. So you have to check pulse in all the peripheral pulses: radial, brachial, carotid, femoral, popliteal, dorsalis pedis, anterior tibial, and the posterior tibial. Don't miss any of these things. And the blood pressure with respect to orthostatic hypotension, because orthostatic hypotension is one of the form of ANS involvement of diabetes. So BP fall of more than 20 after standing for 3 minutes, and the rest are almost same palarectal cyanosis that you have to mention, and vitals, height, weight, BMI. BMI is important because obesity, metabolic syndrome, diabetes, diabetic nephropathy. So that's why BMI is also important. So four important components you should not miss is BMI, pulse, all peripheral pulses, BP for orthostatic hypotension. Rest are almost same. And coming to the head-to-foot examination, fundus should not be missed. If fundus is missed in a diabetic case, it is almost like a gross mistake. So fundus should not be missed. BNF is Brui. If the patient is hypertension, look for Brui. Where to check 2 cm above and lateral to the umbilicus. Or there is a Robinson quadrangle where you can locate the kidney. That much is not required. Just you have to tell 2 cm above and lateral to the umbilicus. N is nutrition. Nutrition, you have to look for skin fold thickness, mid-arm circumference, whether it's undernourished or overnourished, like obesity is there or not. But in this case, the important is the fundus, because majority of the patient will be having retinopathy. That is how the first differential diagnosis have to be formed. So that's why fundus is very, very important. And you have to look for signs of insulin resistance. One important sign is acanthosis nigricans. And other diabetic skin changes like necrobiosis, lipodica, diabeticorum, diabetic dermopathy, diabetic bullae, sclerodema, diabeticorum, diabetic rubeosis. One important thing is you should know what are these, and you should be aware where to look for. This component is also important in diabetic case. Study the theoretical aspect of this. And coming to the systemic examination, the important components tell about the apical impulse, which indicates about the acute or chronic form of hypertension. Tell about organomegaly, Krebs for volume overload, CNS. This is very, very important because you have to assess for almost all the components. Higher mental function have to be checked. Cranial nerve, because in diabetes patient, what is the common cranial nerves involved? Third nerve, seventh nerve is involved. Sometimes fifth nerves also. So you have to look for the vestibulocochlear nerve and almost all the cranial nerves. Pupil is also important, pupillary reflex. And motor system, you have to tell about the bulk, tone, reflex, power. Sensory system is important, very very important. You should have that tuning for pin, you have to check for pain, vibration. So this is where in your exam CNS kit is required. You have to have a CNS kit to examine for all these. And the autonomic nervous system, there is a definitely question they will ask, what are the tests you will do to check for the autonomic nervous system. I will try to upload regarding the autonomic nervous system, because this question will be there, because we have to find out whether the autonomic nervous system is involved or not. For the bedside, you can tell about the Valsalva maneuver or orthostatic hypotension. And regarding the urine dipstick test for protein, is blood, otherwise blood and only protein and glucose is required. That's all. After this, you have to make a complete diagnosis. So this is just a summary. Part A regarding the basic details. Part B, where we got to know about the totally about the how it was diagnosed, what are the drugs, what are the whether it is only diabetic kidney disease or non-diabetic kidney disease, complications, how we have ruled out non-diabetic kidney disease, what are the risk factors for the progression, everything we are obtaining over here. Part C is the general examination having two components, it's the systemic examination and the urine. So now your history and examination is almost complete. Now the complete summary complete and final diagnosis have to be given. Example, if it is a nephrotic syndrome, you have to tell syndromic diagnosis of nephrotic syndrome, etiological diagnosis type 2 diabetes with a microvascular complication in the form of diabetic nephropathy, diabetic neuropathy, with the macrovascular complication in the form of peripheral vascular disease, with the anemia, you have to tell what is the etiology, whether it is CKD related or not. Hypertension, probably secondary to renoparenchymal cause. So there is little bit confusion regarding whether to tell the nephrotic syndrome here or the diabetic nephropathy, then subsequent days nephrotic syndrome. That is not clear, but I am giving you overall idea how we used to present. And we will see what are all the common questions that we usually get in a case of diabetic kidney disease case, either as a short case or long case. If the history and examination is clear, examiner by this time might have a clear idea how strong you are in the subject. So subsequently the question will take to the theoretical part, or in the history and examination only these kind of common questions will come. What is the percentage of diabetic nephropathy in diabetes mellitus? It is approximately 40 to 50%. Both it is same in type 1 and type 2 diabetes. Actually, I have mentioned only the important questions, then just you can assess whether you are knowing the answer for these questions or not. If you are knowing answers for all these questions, almost your final exam, if you get diabetic kidney disease, will perform very well, because the questions will be revolving around here only. And in diabetic case, it is very easy to make diagnosis also and differential diagnosis also. There will be, from the history only, there will be lot of points you will get to say points favoring and points against. So that's why be thorough with this diabetic case. What is the percentage of retinopathy you will get in the case of diabetic nephropathy? Suppose if it's a type 1 patient, if the patient is having, in a case of diabetic nephropathy, 90% might be having diabetic retinopathy. Whereas in the case of type 2 diabetes mellitus, if the patient develops nephropathy, only 60% might be having diabetic retinopathy. And regarding the timeline, Robinson classification, that is basically for type 1 diabetes, not for type 2 diabetes. And what happens to the sugar control when the patient develops CKD? The patient might develop hypoglycemia or hyperglycemia. Why hyperglycemia? Because the insulin clearance by the kidney reduces, and the kidney is one of the components for gluconeogenesis, that also decreases. So the patient is more prone for hypoglycemia. Why hyperglycemia? There is one mechanism, actually I forgot, because of the vascular, because some change in the metabolism, they are more prone for hypo also. Like you can go through the theory part of that. What are the nephroprotective drugs in diabetic nephropathy to reduce the progression? It is also important theoretical question. So you have to tell about AC inhibitor, ARB, SGLT2 inhibitors, aldosterone antagonist, and how much percentage of non-proteinuria renal involvement in diabetes. Up to 20%. Up to 80% usually of this is with respect to diabetic nephropathy. Up to 80% might be having proteinuric renal disease. Whenever there's a predominant glomerular involvement, whenever there's a predominant tubular interstitial involvement, majority of the time patient might not be having massive proteinuria and the diabetic retinopathy staging is very important. Non-proliferative, proliferative. In the non-proliferative, how will you classify, and sometimes management also? What is the role of anti-VEGF drugs, and why the name microalbuminuria and macroalbuminuria changed to moderately increased and severely increased proteinuria? They will ask what is the cutoff with respect to the albumin excretion rate, protein excretion rate, 20 PCR, ACR. How will you say this microalbuminuria and macroalbuminuria, and why the name have been changed? The name have been changed because the name is microalbumin. It is not micro, since the more than 30 gram per day albumin is having a significant risk factor for the progression. They have changed the name to moderately increased proteinuria. And what are all the kidney manifestation in diabetes? They are more prone for diabetic nephropathy. They are more prone for UTI, obstructive uropathy. If we take the non-diabetic kidney disease, membranous nephropathy, dysproteinemia, acute interstitial nephritis, post-infectious GA, these are some of the common conditions. And with respect to the histopathological classification, what is Kimmelstein-Wilson nodules? What is the staging? Staging, I have made a separate video which is in the channel. You can go through that. And what's the normal basement membrane thickness? When will you say basement membrane is thickened? These are all the common questions will be asked. And with respect to the histopathological classification and the diabetic nodule, what is the TD? How will you differentiate? The TD is any monoclonal deposition disease, smoking, and how to differentiate amyloid, monoclonal deposition disease, and diabetic nephropathy. This you can go through. Amyloid is Congo-rate positive, these two are Congo-rate negative, and these are weak. These diabetic nodules are PAS positive, and methenamine silver weak positive. This is both weak negative. And what are the drug side effects? Commonly used drugs: sulfonylurea, biguanides, SGLT2 inhibitors, DPP4 inhibitor. You should know aware of the drugs, EGFR to stop, and when, what are the side effects with each drug, and what are the nephroprotective drugs, and what are the target, HbA1c target, how will you monitor, how long to monitor, and the KDIGO recommendation, target for HbA1c, blood pressure, lipid, they might ask. And if the existing examination is good, if you answer the basic question, then the question will go into the trials. This is also very important with respect to trials. We can divide it as trials related to glycemic control, trials related to BP control, trials related to drugs like SGLT2 inhibitors, sulfonylureas, DPP4 inhibitors, and what are the trials showed how much benefit. I will try to make a separate video for this trials in diabetic nephropathy. So you have to be aware of, importantly, you have to be aware of UKPDS, DCCT, EPIC trial, and important with respect to SGLT2 trials. Since it is the recent nephroprotective drugs, there will be question with respect to SGLT2 inhibitor, DAPA, CKD, and what are the other diabetic and nephroprotective trials which have been shown, and what are the causes of rapid progression in a diabetic nephropathy patient. Suppose if there is no other history suggestive of non-diabetic kidney disease, only history suggestive of diabetic nephropathy, why the patient rapidly progressed, whether there was history of UTI, recurrent UTI. If it is UTI, what is the risk factor for the UTI? And you should know the mechanism why the UTI is increased in diabetes, and why emphysematic pyelonephritis is common. Papillary necrosis is also common. Here I forgot to mention about the papillary necrosis. Papillary necrosis is also important TD for this one. And what are the indications for biopsy in type 2 diabetes or type 1 diabetes? When to plan biopsy? And what are the conditions patient might be in ESRD, but the kidney size might be normal? Diabetes, amyloidosis, HIV. And the question will be reversed. What are the conditions where... Oh, no, that's all. They will be asking this question commonly in the case of diabetes, and should tell about how to check for ankle brachial pressure index. What is the normal range? Because if a patient have peripheral vascular disease, the question will come regarding that. See, these are all the important questions I am remembering. And the rest though, you can go through the theory part regarding the pathophysiological mechanisms and all. And one other important question which usually comes is, what is the mechanism by which SGLT2 gives protection in non-diabetic CKD? You can go through that. Basically, it reduces the hyperfiltration through the tubulo-glomerular feedback inhibition and the much energy need in the glomerular by blocking the sodium potassium ATPase, so that the kidney energy and hyperfiltration reduces, so the progression reduces. And the management of diabetes overall, how to tell, like glycemic control, BP control, nephro protection, infection protection, peripheral vascular disease protection, diabetic food care. Like, we have to go through the guidelines to mention all these things. And the drugs for peripheral neuropathy, they might ask about the dose, complication, what are the things to look for. And there are so many other questions we can keep on discussing, but I will finish over here just so you can study the theory part of this. So this is all regarding diabetic, any diabetic nephropathy with the renal dysfunction case. If this case is available, hopefully with this history and the basic knowledge of the content and the patient profile, you can make the differential diagnosis. And usually a diabetic kidney disease, if we take, it is usually easy go. So all the best for your exams.